I'm standing now at a 3D Med pelvic trainer. This is the kind of pelvic trainer that I use to build my laparoscopic skills. We use the pelvic trainer and not the time in the OR because there should not be a patient's life at stake while you're building your skills. This is a low pressure scenario in which learning is maximum and optimal. So I am using the pelvic trainer, but I have it situated exactly like the patient is on my operating room table. The video comes through the patient's umbilicus. I am situated on the patient's left. Why is that? Well, because I'm right-handed, and the physiologic motion in suturing is to suture towards your own midline, which would mean suturing towards the vagina on a patient by standing on her left. If you are left-handed, you'd want to stand on the patient's right. Now, I use a diamond configuration in the patient's abdomen, and so I've created the diamond configuration on the pelvic trainer. Adjust your height. Raise your height by adding lifts at the table. I almost always use a lift, even though the table is as low as it'll go, and so adjust the table down. My patients are always in steep Trendelenburg at 33 degrees, so that all the intestines fall to the upper abdomen, and so that I'm working clearly and cleanly and nicely in the pelvis. So this is the position where I'm standing straight, my elbows are by my side, my trapezius is not strained, and I hold my non-ratcheting grasper in a loose fashion, and I hold mine upside down compared to everybody else. I think a lot of other people would hold it like this, but look at the strain that it's going to create. So I use my Care Fusion grasper in a non-ratcheted fashion to pass my knots, and my ratcheting hand on the needle driver. I use a ratchet on my needle driver because I definitely need to have a strong grasp of the needle so that it doesn't wibble wobble when I am suturing. So having reviewed the ergonomic basics, now we'll talk about the structure and the nomenclature, the name for the suture anatomy, so that we will know what we're talking about when we're giving instructions. The needle, of course, has the pointy end and the hub end. We call it the hub because that's the end that holds the suture, and that's the end we use to wrap the suture around the needle driver with our non-dominant needle grasper. Now, between the hub and the tip is an area within the needle that we call the belly of the arc. When we're trying to wrap the suture around the needle driver in preparation for our knot, we put the tip of the needle driver in the belly of the arc, because that way the suture can't wrap around it because it's next to the needle. You'll see what I'm talking about in the real life demonstration. So we're going to pick up the suture and we're going to close this pseudo-vagina. I'm going to reach for the needle and I'm going to push it into the tissue, which helps me to orient it in a right angle. If I needed to, I could just pick up the suture and pull the needle into perfect position. Now I'm going to pick up the edge of the quote vagina. To overcome the lack of three-dimensionality in the pelvic trainer as well as during laparoscopy, I will simply use the side of my needle to show me when I have touched the tissue. Then I will back away from it and pass the needle with great precision. I'll pass the needle all the way through, and without changing the orientation of the needle, my grasper will lift it. I'll hold the tissue with my needle driver and pull it through without changing the orientation. Now, for maximum efficiency, I'll re-grab the needle in the exact sweet spot, which is about 2/3 of the way from the tip of the needle to the hub of the needle, and I will move the suture through the incision with both instruments maximally efficiently and in good control. I'll lift up the anterior lip of the vagina, touch it, back away, and pass the needle through it, turning it all the way so that I can re-grasp it without changing the orientation. Stabilizing the tissue, I'll pull it through, and then I will re-grab with no wasted motion and pull the suture through. Note that I left a very short tail, about 2 centimeters. So let's continue with this figure of N. We'll pass the suture through, pull it without changing the orientation. I will continue to roll it through. We will tighten it because you don't want to be pulling the suture through the entire figure of N. Touch the tissue to know exactly where I am and pass it through. Now we're going to tie the knot. I'll pull the suture through. We're going to tie the knot. Now, I will want to align the hub of the needle with my driver, so I'm just going to pull it towards myself. These are now parallel, and it will allow me to use the needle to wrap the suture around the needle driver. I'll pull back to control where the wrapped suture goes. I'll keep it on the needle driver, and then I will move forward and pick up the loose end of the suture. Now I will pull down the length of the needle to disgorge the knot from the needle, and I'll pull away from the knot with the needle driver. And there we have tightened it. Now for the second knot, and I've placed a surgeon's knot there. In real tissue, I would place this suture back on the moist tissue to hold it there, so that after I make my next knot, all I need to do is lunge forward to pick it up. But in this model, in the pelvic trainer, we can't get this to stay over here, so I'll just leave it there and find it wherever it is. Now it happens that the hub of my needle is lined up perfectly, but if in the process of pulling the knot tight it had changed, I would simply reorient it to point directly down the length of the needle driver. I will wrap it once. Let's wrap it in the other direction since I wrapped it the other way first. I'll lunge forward to pick up the needle, and wouldn't it have been convenient if it was right there? We'll pull it down the needle, and we will tighten our knot very nicely. Now, anticipating future knots, I'm going to again put the loose end of the suture on the tissue, and it still won't stay because it's still not moist. I can wrap one final time. I could lunge forward to get it, but I'll find it over here. Now, in real life, if you do have to go moving around, move the entire needle driver complex. So we move together. We move together so that we don't disgorge our tie. And then I'll pick up the loose end of the suture, and there's our third tie, placing it, not staying again. Okay, whoops, and this will happen in real life. It does to me. And our final